You can all hear me clearly. So good afternoon to all of you. Good afternoon to our colleagues from Ethiopia. My name is Dr. Kevin Raphael. I work with Assist International. In Tanzania. I am glad to be facilitating Dr. Ananya's echo session or travel from the Stanford University. So I will begin by taking you through the introductory slide. So today at May 25, 2021, this is our launch, our first session. And we are going to go through considerations for triage and the main resource that we're going to be used for today's session will be Dr. Ananya Bates from the Addis Ababa University College of Health Science, School of Medicine, and TQ and
Hi everyone, I think Kevin is having audio difficulties, so I'll just step in to do the introduction.
And so we're going to have another corner co-panelist. We will have Dr. Jonathan Abebe from the Amsterdam.
Hi, I think, Dr. Kevin is having some audio difficulty, so I'll just step in to do the introduction. My name is Alana, and I'm from Assist International, and I'm pleased to welcome you here today to Session 1, Considerations for Triage of the Oxygen Therapy and Critical Care course. Today, we are pleased to have Dr. Ananya Abate from Addis Ababa University College of Health Science, School of Medicine, and Takura Mbesa Specialized Hospital, and joined by panelist Dr. Jonathan Abebe from Ras Desta Damto Memorial Hospital and Dr. Sophia Kabede from Addis Ababa University College of Health Science. Before we begin, we do have some housekeeping items. So just to start, our programming is based on a foundation of love and respect. So please respond kindly rather than react if you disagree with something that is said. It is everyone's responsibility to keep the webinar a safe space. We will be using the chat function for question and answer. The button to do that is at the bottom of your screen. Please send all questions that you have through the chat box and feel free to introduce yourself. If you can, turn on your video and position your webcam effectively to show your face if alone or to capture the whole group. If your internet bandwidth is poor, you may consider keeping your video turned off so that you can save your internet capacity. If you have any technological issues, send a message through the chat. We have a team here to help you. And the session is being recorded and your attendance is consent to be recorded, so thank you. Finally, please be mindful of infection prevention and control. Try to limit the number of people joining from one gathering place and practice physical distancing. And so with that, I'll hand it over to Dr. Ananya to get us started.
Thank you, Alana, for your nice introduction. Welcome, everyone. This is going to be our first session of the Ethiopia Oxygen Therapy in Critical Care training program. Today, we have panelists with me, Dr. Jonathan and Dr. Sophia. It's good if they introduce themselves. So, Dr. Sophia, can you just say hello?
Yeah, okay, thank you. Thank you, everyone. My name is Sophia Kabede. I'm an emergency and critical care specialist in the Kurambasa Specialized Hospital. And I'm glad to be joining you guys to talk about oxygen and triage practices today in this session.
Okay, Dr. Jonathan.
Okay, thank you all. Hope you hear me clearly. I'm Dr. Jonathan, consultant and solution critical care specialist. Currently, I'm working at Rastus Adamto Memorial Hospital COVID ICU, and I'm really glad to join you for our today's discussion on oxygen therapy and also on first session. So thank you again.
Okay, I'll try to share my screen. So is it visible for everyone?
Yes, looks great.
Okay. Thank you. So
Yes.
in this program, this is a program designed for global, but locally we can also implement it in our context, in our setup. So it's free to use whatever language you are free with, local language, meaning like Amharic. But for the sake of involving all participants, we'll try to use English as much as possible. And it's going to be, a case-based discussion. We'll give you a case, and you participants will write some of the answer for questions we are going to provide on a chat box, and our panelists, will elaborate on the answers, and I will be facilitating the overall progress of the program. So to help you, in following our sessions, you will be provided a link for to get the Learning Resource Center, where you'll get all the materials, including the presentation, videos, and also reference material for some of the most important pointers in our slides. So this will be sent to you via email and Telegram group. And when you open, your Learning Resource Center, you'll see, a lot of series like Oxygen series contains part 1 to part 2 sessions, and you can click on the session and see and find all the materials you want. So just today we will be focusing on the first session, which will be consideration for triage. So I will start our session by giving a case scenario, but before doing so, I would like to tell you what today's objective is. It's not like a learning objective. It's something we say practice change objective, because we want you not only to acquire a knowledge, but we want you to change that knowledge into decision makings and action. And then after doing, some action items, you have to also follow and monitor those actions. And that's what we call a practice change objective. So by the end of the session, we'll expect healthcare providers to follow recommended PPE guidelines, and to be trained in safe donning and doffing sequence for PPE, and identify potential contagious infectious patients and isolate early. We want to have screening methods for SARS-CoV-2 in place, and healthcare providers recognize and diagnose hypoxemia, use pulse oximetry to appropriately triage hypoxic patients, and manage using a non-invasive oxygen therapy. So all these things, you need to do it by the end of the session. It's not just knowing the facts. And to help you with that, we'll give you now a almost real case scenario. So throughout the session, you have to remember the case. It is a 57-year-old man presenting with chills, weakness, and dry cough. So let's say this patient presented at the emergency room. How would you evaluate this patient further? So you can provide us your answer in the chat box. So he's a 57 years old man, chills, weakness, and a dry cough. So we need, your participation. So just feel free, write in whatever language you want, how you would evaluate this patient further. I will be looking into chat. Yeah, very good. ABC of life. So I'm seeing ABC of life. Any other trial? Yeah, feel free. You can write whatever you like. So far ABC of life. Yeah, take infection prevention precautions. That's very good. So yeah, Dr. Sophia, I mean, how would you evaluate this patient further? You are emergency and critical care physician at the emergency or PD, and you find just such patients.
Yeah, I was looking at the chat box on what our participants are saying. So ABC of life, take infection prevention precautions, check vital signs, every sign, vital signs. So if they have more answers or if they want to elaborate, we can give them a minute or two, or else we can, start discussing on what the participants are saying and how to really do these things from the patient's perspective.
Yeah, so far we are seeing check vital sign, follow the triage protocol, first check vital sign, and all the answers are very good. So maybe let me hear.
Yeah, so I think, yeah, all the answers are very good. What it needs is just tying up everything together, and also sequence of events, what should follow when. So all the answers that I'm seeing here are right in their own way. So this guy came into the emergency room. He has cough, he has chills, rigors. So since we are in the COVID era, the first thing we have to consider for every patient actually that comes into our emergency is IPC precautions. So infection prevention comes first. Health professionals should protect themselves. They should also protect other patients. As we know, our emergency is a very crowded area. So IPC precautions, that should come first. So patients should have their own mask, and I believe there's a more discussion on donning and doffing of health professionals, but all health professionals should have the minimum required PPE when they're dealing with such patients. At least they should have N95s, gloves, if possible, even goggles and some face shield. So after instituting this IPC precautions, the other thing to do will be to check the vital signs and also to do the ABC of life. They're usually done simultaneously. So when we say ABC, that's in short. A is for the airway, is the patient's airway pattern. Is he talking? Is he breathing? B, we can check that if he's talking and expressing other things to us. On B, we have to check his breathing. Is it labored? We can count the respiratory rate and see if the patient is in distress. And in the meantime, we can check the saturation in the triage area and see, we have to see the circulation, how his blood pressure, his pulse and everything. So by doing this, by instituting the ABC of life, we also check the vital signs. Another thing in this patient, obviously, we're thinking of COVID at the back of our mind. Someone said, Dr. Gosa said, consider it as COVID unless otherwise tested. That's right. So we have to see if we can isolate the patient, the sooner the better. And we have to see the distance that we're keeping between patients and everything. So these things are individualized to every emergency, but the isolation, the distance and everything. But checking the ABC of life and the vital sign and seeing that the patient is doing well, that should be done similarly in all patients.
Yeah, thank you, Dr. Sophia, and all the participants who wrote on the chat box. As you said, the second thing to do is, further evaluating the patient. You do proper history, physical exam while protecting yourself.
Yes.
If you want to see, what's prepared from the program organizer or the one who produced this program, you can click anytime on the question marks. Now, for the sake of time, I will not be doing it here because it's well addressed, but you will get a material if you want how you are going to evaluate this patient further. But proper history, physical exam while protecting yourself is something you are going to do, and we all agree.
Yeah.
Now,
so
let's say
that's considered as the secondary survey. So we did the primary survey at the ABC of life, and then secondary survey, you should do detailed history and physical exam.
Thank you, Dr. Sophia. So now let's say you decide to perform history and physical exam in this patient. When you interviewing the patient further about the history of present illness, you discovered he has a 4-day history of chills, weakness, and dry cough. And his wife is a nurse at the hospital and tested positive for SARS-CoV-2 3 days ago. His wife has a pulse oximetry at home and had the patient check his oxygen saturation, and the reading was 89%. So his wife sent him to the emergency department. Now the question is, should you be wearing PPE when you hear this history? Straightforward, easy question, but we need your participation. So write something. Should you be wearing PPE? Definitely yes, yes, yes. Of course, yes, yes. A lot of people are saying yes. These days, PPE should have been done in the first interaction. Definitely yes. So many people are saying we have to have PPE in place. So I'll give also the chance now for Dr. Sophia, if you want to say here something.
Yeah, so we've mentioned this earlier, Dr. Ananya. So from the chat box, someone said IPC should be instituted in this patient earlier. So the same thing came here. We should think of infection prevention measures before dealing with the patient. So now our participants are all smart. They all know we need PPE. So we have to think of these precautions before dealing with the patient, before taking the history, before doing the ABCs. Even before triaging any patients, whatever we have in our setup. I know it differs. For personal protective equipment, we may not have everything in our setup, but whatever we have to protect ourselves. So we have to use whatever we have before coming in contact with the patients. And as Ananya, you were telling us the history, the blood thickens, the wife is a nurse, so she may be in contact with COVID patients. The patient saturation is low, she has some symptoms. So this is definitely a red flag for us. And as everyone is saying, we should definitely wear PPE, whatever at hand we have when dealing with this patient.
Yeah, there is also, Center for Disease Control, PPE recommendations, depending on, if it's a suspect or COVID positive.
Yeah.
Or whenever we have a community spread, then we may expect everyone coming to emergency as a potential COVID positive. So in line with that, we need to have protective equipment in place, and we have to be ready with that, right? So if you want to see the Center for Disease Control PP recommendation, there is a printable infographics in the Learning Resource Center, and you can easily see that. Maybe it's good to see, some videos how to safely put on personal protective equipment in the current situation, and yeah.
Dr. Ananya, we can't hear the video. Would you like me to share my screen to show it?
Yeah, is it audible?
No, we can't hear. I think when you click share screen at the very bottom, you'll see optimize for sound.
Sorry if it's not audible. Maybe can you help me share the video?
Yes, yeah. I'll share it for you. 1 second.
How to safely put on personal protective equipment, or more commonly called PPE. We will demonstrate one way to appropriately put on or don PPE. More than one donning method may be acceptable to your facility. It's important that you receive training, demonstrate competency, and practice your healthcare facility's donning procedure. First, identify and gather the proper PPE to don, including an appropriately fitted isolation gown, a NIOSH-approved N95 filtering facepiece respirator or higher level respiratory protection, or if a respirator is not available, a face mask, a face shield or goggles, and a pair of disposable patient examination gloves. Perform hand hygiene by using alcohol-based hand sanitizer or washing your hands with soap and water for at least 20 seconds. Put on the isolation gown. Tie all ties or snap all snaps. You may need assistance from another healthcare provider. Put on the N95 respirator. When using a respirator with a nose piece, fit it to your nose using both hands. Do not bend or tent the respirator. Extend the respirator under your chin, protecting both your mouth and nose. Pull the top strap over your head, placing it on the crown. Then pull the bottom strap over your head, placing it at the base of your neck. Lastly, perform a user seal check. Do this by using your hands to cover the surface of the respirator and gently exhale, checking that the facepiece bulges slightly. Then, while keeping your hands over the respirator, take in a quick, deep breath, checking that the facepiece collapses slightly. If air escapes through the edges, readjust the fit of your respirator and perform another user seal check. Do this each time you put the respirator on. If a respirator is not available, put on a face mask. Extend the face mask under your chin, protecting both your mouth and nose. If the mask has loops, hook them around your ears. If it has ties, secure them at the base of your neck and crown of your head. Next, put on a face shield or goggles. Lastly, put on your gloves. Pull the gloves down so that they cover the wrist of the gown. You are now ready to enter the patient's room.
Yeah, thank you, Alana. It was a very nice video. I think I'm sure all of you have done this before, but it's good to have to see it again and again, to be more familiarized with it and to do it right away whenever you are facing a patient who are likely to be infectious from COVID-19. So the most important part of PPE donning and doffing is, to protect yourself from contamination, and contamination usually occurs during doffing procedure. So can we see also a video? Alana, can you please share that for me if you have it? Yeah, doffing procedure.
How to safely take off personal protective equipment, more commonly called PPE. We will demonstrate one way to appropriately take off or doff PPE. More than one doffing method may be acceptable to your facility. It's important that you receive training, demonstrate competency in removing your PPE without contaminating yourself, and practice your healthcare facility's doffing procedure. Remove and discard your gloves. Gloves can be removed using more than one technique. For the glove and glove technique, pinch the outside of the glove near the wrist. Peel downwards, pulling the glove inside out. With your ungloved hand, slide your finger under the wrist of your remaining glove. Again, peel downwards, turning the glove inside out. Discard the gloves. For the beaking method, pinch the outside of the glove near the wrist. Using your finger, pull the glove inside out and over the fingers and thumb to form a beak. With the beaked hand, pinch the opposite glove at the wrist and pull downwards, turning the glove inside out. With the ungloved hand, pull the beaked glove off, touching only the inside of the glove. Next, remove your gown. Untie all ties or unsnap all snaps. Some gown ties can be broken rather than untied. In that instance, break the ties gently, avoiding a forceful movement. Reach up to the shoulders and carefully pull or roll the gown down and away from the body. Dispose of the used gown. You may now exit the patient's room. Perform hand hygiene by using alcohol-based hand sanitizer or washing your hands with soap and water for at least 20 seconds. Be sure to clean your wrists where the edge of the glove was located. Carefully remove the face shield or goggles by grabbing the strap and pulling upwards and away from your head. Do not touch the front of the face shield or goggles. Next, remove and discard the respirator or face mask. If you are wearing a respirator, remove the bottom strap by grabbing only the strap and bringing it carefully over your head. Grasp the top strap and bring it carefully over your head, and then pull the respirator away from your face without touching the front of the respirator. If you are wearing a face mask, carefully untie the straps or unhook them from your ears and pull the mask away from your face without touching the front of the mask. Lastly, once again perform hand hygiene after removing the respirator or face mask. You have now completed the doffing procedure.
Yeah, thank you, Alana. Also, if you, let me go back to my screen share. So this is a good video which showed, how to don and doff. But I would like also to share, the graphics. Maybe Alana, can you help with that as well, or I can run from your slides if you want. Yeah, so the CDC's using personal protective equipment. If you go to the Learning Resource Center and click on the PPE gear or the CDC's how to don and off. Yeah, good, Alana, you are showing here. So from this slide or from this screen, if you click on personal protective equipment, the Center for Disease Control, you can find different graphics showing how to don and off and when PPE is needed. There is a recent recommendations, so you have to use those graphics if they are not already available in your setup, post it in the wall so that everyone can remember and can be guided with these graphics. So the good thing about this graphics is it can give you also, options like the preferred one. If you are seeing on the screen, the most preferred one is using N95 mask as a part of PPE. But in places where you don't have N95 mask, you can use also a surgical mask, and that's something seen on the right side of the slide. So the CDC infographics is very important to be utilized in our setup, resource limited setup, and you see how easy it could be to triage and manage patients who are COVID suspects or even COVID positive. So let's go back to the PowerPoint, Alana. Yeah, so can you make it a little bit larger, the fonts a bit larger? Yeah. So is it visible for everyone? If it is, show your thumb like this. Visible for everyone? Yeah, I think for me it's quite invisible, and someone is showing me his thumb, so it's visible. So far we have gone through, discussion points, and after these discussion points, you have to take some practice change action items. So at your setup, we'd expect you to create training session for all providers in safe PPE don and off sequence. You have seen the video, and you can get the video later as well. I would like you to print PPE infographics and display in relevant patient care areas. It could be as emergency, OPD, ICU, and wards. And also place PPE checklist on doors of person under investigation or COVID positive patients. So all those materials are found in the Learning Resource Center, and please practice that. And when you practice that, is when we see a change. Now, if I say so, then remember the patient is 57 years old with chills, weakness, and dry cough, and is also a wife of a nurse who's COVID positive, and is just present to your emergency OPD. So how would you triage and isolate this patient? So as usual, can you write on chat box how you triage and isolate this patient? Yeah, looking into chat box. I think someone is writing, but I cannot see what's written there. So I'm saying yes, so that means probably you are saying you will as okay. Take her to a COVID suspect waiting area. Very good. Someone said I will take her to a COVID suspect area. So how would you triage, isolate? Yeah, I think, yeah, prepare a separate area or space until COVID result arrives. It's from Emmanuel. Thank you, Emmanuel. Oh, from Fukray, give her a surgical mask. Very important point. Give her a surgical mask. Yeah, I will give some seconds as well for those of you who wants to say something. So far, we're having interesting. Yeah, triage as yellow. Take him to the isolation area from Zamet. Thank you. So you have said so many interesting things. I would like, to forward also. So yeah, from Chernet's high possibility to being positive. Oh, so many chats are now coming. From Henok, make the patient wear medical mask first, then put into isolation area. Very good. High possibility to being positive, so trace contact with other family members too. So many things are being said, and it's right and correct. So maybe we'll see. I will open the floor for Dr. Sophia. Maybe can you just summarize how we do triage and isolation, maybe in our setup?
Thank you, Dr. Ananya. So everyone's answer is correct in its own terms. So this patient is very likely to be COVID positive. So we have to isolate it, to isolate him, sorry. So wearing the mask, the oxygen support, all this goes. So we have talked about the IPC. So when we talk about infection prevention, we have to make sure that our patient also has at least a surgical mask on him, and the patient should know how to institute preventive measures. Like when he coughs and sneezes, he has to cover his face and everything. Till we isolate him, we have to at least see that he practices these measures. So the most important thing in this patient is that the saturation that we are told is around 89. So he needs oxygen support. Other vital signs, I think, are normal. He's a bit hypotensive, I think. So when we triage COVID patients, The other thing that we should consider is there other than the vital signs, does the patient have other concomitant illness? We have to see that. So with the vital sign and the other symptoms, we can categorize them as mild, moderate, or severe COVID. So this patient has symptoms, he has desaturation and other vital sign instabilities. So at least he has moderate COVID. When we isolate, it's not only taking the patient to another place. We have to make sure that he gets at least oxygen support, maybe fluid and other treatment in that isolation area. So sometimes the isolation area for COVID patients may be away from the emergency. Like in our hospital, the isolation center is very far from the emergency. And whenever we're isolating such patients and taking them to another setup, we have to make sure that the care that they need continues with them. That's the most important thing that we can get from the triage. So whether we triage this patient as yellow or as moderate, it's the same thing. We have to make sure that he gets at least oxygen and other needed treatments before when taking them to the isolation area. Otherwise, all the answers seem to be correct.
Thank you, Dr. Sophia. Alana, can you click on the question? Yeah, so we have a standard operating procedure for triage of suspected COVID-19 patients in non-US healthcare setting by CDC. And, you know, early, it has got a lot of things as a content, but what we want to know is, you know, what patients can do before and upon arrival to health facility. You know, these days, informing healthcare providers through phone should be told to patients through mass media whenever they have a COVID-19 symptoms. It's better if they don't show up in hospital and can get their, you know, kind of communication from home through phone. And whenever they have to come to hospital because they have a danger signs and they have to wear a mask. It could be a medical mask, or if it's a non-medical also, we have to tell what type, you know, which having, you know, 3 layers and so on. And from our institution point of view, you know, we need to set up in the equipped triage area, screening area. We have to differentiate it from the facility. And we need to have, you know, standardized protocol how to triage. All these things are written in a document which Alana is showing us now, the CDC recommendation. If you can click, Alana, on the CDC triage algorithm, I'll be very happy. If you go further down on the slide, on the same document, if you go further down on the slide and you find algorithm, maybe down, go the slide further down. Yeah, triage of patients with suspected COVID-19. In case of, you know, if there is a limited community transmission or a widespread community transmission. So if you lower it further down in a widespread community transmission, where we are expecting. So Alana, can you just put the slide further down? Yeah, this is triage of patients with suspected COVID-19 with widespread community transmission. You know, you identify common signs and symptoms of COVID-19. If there is acute onset of fever and cough, or at least 3 signs or symptoms, then you have to place medical mask on the patient and separate from other patients and inform hospital infection control program and the other appropriate staff. If there is no, you know, common signs and symptoms of COVID-19, then it's now the CDC's recommendation to continue with usual triage assessment and care. So such kind of, standardized protocol needs to be placed in our settings, and is a good resource, and you can use this resource. Dr. Sofia, do we use this on our emergency OPD, CDC's triage protocol algorithm whenever there is a widespread community transmission?
I was thinking that we can start using it. Till now,
Yeah.
we're not. Honestly, we're not. It's, I mean, the algorithm as well. Then I was just looking at it. So if we can post one and at the triage area and also teach our residents to use it, I think it would be great. But for now, we're not using this one.
Yeah, so everyone, who's participating in this session, make use of these materials. They are very important. They make things easier, and it improves the quality of service. Yeah. So thank you, Alana. I think we can go back to our presentation. So I think you have got some, something, some concept on how to triage and isolate patients, and also some practice items as well, and the reference materials you want. Now I will go to another discussion point. Then how will you screen this patient for SARS-CoV-2? And in the meantime, also think of other presenting symptoms of SARS-CoV-2 infection. So you can write answers for this question on the chat box. I'm sure you remember the case of this patient. He's 57 years old who just presented at emergency OPD with chills and a dry cough and weakness, and his wife is COVID positive, and the nurse who sent him to emergency OPD because she measured his saturation at home, and saturation is 89. So how will you screen this patient for SARS-CoV-2? And what are other presenting symptoms? Okay, so now people are writing on chat box. Let me see from Yared. We have to wear PPE before contacting the patient and check for symptoms like difficult breathing, high fever, myalgia, coughing, etc. Very good, Yared. I agree completely. And anyone else who wants to write on the chat box? I see only Yared, and he really wrote it very nice. So someone, Subalo is writing some of the symptoms of COVID-19 as loss of appetite, anosmia, and loss of taste. Excellent. And from Galaxy A5, maybe I don't know the name, but by sending sample to laboratory, so laboratory test as a screening. And from Zamed Galata, history and physical exam, symptoms like cough, fever, myalgia, fast breathing, GI symptoms, shortness of breath, contact history, and PCR testing for SARS-CoV-2. Thank you. So I think it's not only Zamed Galat, I think so many people are joining us from the same device, like I can see Zamed, Mehret, Noura, and some other people are also joining from the same device. Thank you very much. And I assume now you are having personal protection, having a mask and also distancing when you are joining our session. So from Fugray, ask about contact history with COVID patient. Thank you. I think we have enough participation from you guys. Thank you. We know that you are with us. You are attentive. Maybe I'll give again a chance for Dr. Dr. Sophia. Can you run on this? Also Alana is displaying some of the common symptoms of COVID-19. Cough, shortness of breath, fever, chills, muscle ache, vomiting, diarrhea, and the new loss of taste or smell. So most of them are already, described or said by our participants. So is there, Sophia, from, our country point of view, which symptoms are really common, pathognomonic, if there are any, and so on, and how is the screening process looks like, any recommendation from in Ethiopian context?
So these are basically the symptoms of COVID. We usually classify them into the typical and atypical ones. The typical ones are the ones in the first row: the cough, the chills, shortness of breath, fever. Those were used first for while patients were being screened worldwide, and then the atypical symptoms, the GI symptoms, the insomnia, and everything were added. Maybe what we are forgetting here is there are also asymptomatic patients. So we may have asymptomatic patients that have contact history from family or whatever, and they may turn out to be COVID positive later. Otherwise, these are basically the symptoms that we look for when we're trying to triage patients. So there's also a paper from Yekka Kotabe that was printed. I don't have the link now at hand, but I can share it later. So the symptoms of COVID, they try to see the symptoms and sign and symptoms of COVID patients and the percentage. And the highest percentage, from what I remember, was with the typical symptoms of fever, cough, chills. Those had a high number. From the atypical symptoms, loss of smell and taste, insomnia, that also had a higher number. The GI symptoms and the other were rare, and there was a small number of patients that were asymptomatic. That's what we have from our context regarding the symptoms and signs of SARS-CoV-2 patients. In the meanwhile, the other question here was how to screen these patients. So we have how to screen this patient. So we all have this high index of suspicion about our patient from the symptom, from the contact history and everything. So we have talked about the infection prevention, the isolation. Now the next thing would be to take sample and test PCR for COVID. So all centers are doing PCR. It can be done from the upper or lower respiratory tract. For screening, we use the upper. And from the upper, we can use the mouth or the nasal mucosa. So this patient will need to give a sample. Sample taking may differ from centers to centers. In large hospitals, there are trained individuals that will come and collect from patients. Earlier, before there was this nationwide training for COVID of health professionals, what we used to do was to call the APHI. Everyone knows the number. We used to call professionals from APHI. They come and take the sample. But now in every large institution, there are trained professionals. They can come and collect the sample with their own PPE and their own materials, and then that will be sent to the lab and it will be tested. Still, we have certain labs in the country that the testing is taking place. So they will contact back the health professional or the hospital when the result is ready. So trying to see answers from our participants. Everyone is actively participating, which is good. So we are on the same page. So send sample to lab, PCR testing, and the symptoms and the signs. Everyone has a good grasp of.
Thank you very much, Dr. Sophia. I don't have anything more to add. Maybe, from some of the studies in Ethiopia, they said that, patients who have loss of taste or loss of smell as a presenting symptom most likely will turn out to be COVID positive.
Yeah.
I don't know. Yeah, this is something maybe to consider as you know, patient with highly likelihood of being COVID positive. So yeah, using symptoms and PCR testing is something we want as an answer, and everybody seems to be in the same page. And Dr. Sophia, you really explained it in a very good manner, and thank you very much. So let's proceed to the presentation. Alana, we are making you busy, sorry. Yeah, so far from our discussion, what are the practice change action items? You guys have to establish screening station outside facility, identify screening personnel and questions, use a screening checklist, screen everyone, including workers and employees, use telephone appointments and algorithm for triage when possible, limit entrance points to facility, post visual alerts at entrance points, triage high risk and symptomatic patients to areas of isolation, provide hand washing supplies and ensure face coverings, and ensure waiting areas are well ventilated and seats are 6 feet or 2 meters apart. So to help you in doing this, you have all the materials contained in the Learning Resource Center, and that the link Alana will be sharing through the Telegram group and as well as email group, and you can use all of them, and I'm sure our practice will be changing. So let me update on the case, and we'll continue through our discussion. So yeah, thank you, Alana. Now it's quite visible. The patient in your further evaluation, say he denies fever, shortness of breath at rest, headache, loss of taste or loss of smell. He's talking in full sentence, but states he began short of breath with moving and eating. He has been less active and is mostly staying in bed or on the couch. A nurse at your side obtains the first set of vital signs, and the vital signs are like heart rate 95, blood pressure is 95 by 52 millimeter of mercury, respiratory rate is 24 breaths per minute, saturation of oxygen is 89%, and temperature is found to be 37.5 degrees Celsius. Now looking into this history and first set of vital sign, what do you think is this? So what is hypoxemia, and what is hypoxia, and what is the difference? Most of the time, these things are using interchangeably, but there is a difference, and we need to know that. So can you write something about the difference between hypoxemia and hypoxia? And we can see it in the chat box. So from Isaac, hypoxemia is low oxygen level in blood. Exactly. And someone said, yeah, Muskana, hypoxia is oxygen deficiency at tissue level, while hypoxemia is in the blood. Excellent, very good. Group of people, they said hypoxemia is a low partial pressure of arterial oxygen. Hypoxia is low oxygen level in the tissue. Hypoxemia is low oxygen level in the blood, but hypoxia is low in the tissue. Yeah, so everyone, Abraham, Shete, Sisai, so everyone is defining what hypoxemia and hypoxia is, and fantastic, it's very good. We have Dr. Jonathan with us, the anesthesiologist and critical care specialist. So can you say something on what hypoxemia and hypoxia is?
Okay, thank you, Dr. Ananya. It was a good introduction, and I've seen people from participants, and we have seen, as we have said, usually there is misnomers of using this hypoxemia versus hypoxia. And commonly, as for clear definition of hypoxemia, it is, as others as mentioned it is mainly a decrease in oxygen level in the blood. And as the other part will be hypoxia, which might be, or the final part, or poor oxygen delivery as a tissue level, which might have presentation up, or the hypoxemia, and the hypoxia is mainly at the tissue or mainly at the organ level. That's usually I have seen it as misnomers, or people used it interchangeably, but they are quite close pathophysiologically, but they are representing different things. So as a repetition, hypoxemia is a low level of oxygenation at the blood level, and usually the hypoxia is at the level of the tissue perfusion. So mainly, if you discuss about hypoxemia, usually hypoxemia can be, and we can pick it either by two methods. One is a non-invasive form, which commonly we use it in different setup. The less invasive one, which is a pulse oximeter, we have it almost every other center, especially past 1 year. We have faced a lot of problem facing with COVID and its complications. And the other, the non-invasive form, other than the hypoxia, the pulse oximeter, we can use like direct measures of the invasive one, which is more painful. From the arterial blood gas analysis, we can obtain arterial oxygen saturation level, or we can also obtain the partial oxygen level from the arterial. But it's usually recommended to use the pulse ox, which is the easiest, the cheapest, and the less invasive one. And as a summary, hypoxemia, let's define it as poor oxygen level at the blood level.
Yeah, thank you, Jonathan, for your nice description of the difference between hypoxemia and hypoxia. If you can click on the blue thing, Alana. Yeah, because we have also a video.
Diagnosing and treating hypoxemia requires providers understand its definition and how to detect hypoxemia using pulse oximetry or arterial blood gas analysis. When we breathe, we pull air into our lungs. Room air contains 21% oxygen. When oxygen enters our lungs, it travels to the alveoli, where it diffuses from the alveoli into the pulmonary capillaries. Oxygen then either binds to hemoglobin within the red blood cells or diffuses into the plasma. This is called oxygenation. Insufficient oxygenation is called hypoxemia. The rate at which oxygen is delivered to the cells and tissues of the body is known as oxygen delivery. Inadequate delivery of oxygen to the cells, tissues, and organs of the body is known as hypoxia. Every cell of the body requires oxygen for cellular metabolism.
Yeah, I think it's enough if we go so far. Yeah, so I think as Dr. Jonathan clearly described, it's just additional point of video how to differentiate what is hypoxia and hypoxemia. So let's go back to the presentation. I think you have, most of you look like you have a good understanding about the difference between hypoxia and hypoxemia. Now we want to know, what are the common cause of hypoxemia? So please again write on the chat box the common causes of hypoxemia. Waiting, what are the commonest cause of hypoxemia? You can write, anything. So anemia, ARDS, asthma. So a lot of people are now writing. Pneumothorax, pulmonary edema, hypoventilation, diffusion problem, VQ mismatch, reduced oxygen tension, very good heart failure, type 1 respiratory failure, carbon monoxide poisoning. So the list is very long. So congenital heart disease. Yeah, more than satisfied. So maybe I'll give the chance for Dr. Jonathan if he wants to add something on common cause of hypoxemia. Yeah.
Thank you again. It has been mentioned a lot of pathophysiologic or different disease conditions, and we can mention a lot of problems starting from neonatal ages or newborns and infantile periods, and also pediatric childs up to 1 year, and usually in the pediatric and also in the adult, multiple causes. It has been mentioned by most of our participants, and it was really quite interesting. But we can define usually with cause of hypoxemia, which is a decrease in oxygen level in the blood. We can classify it, or we can create it as a pathophysiologic mechanism might help us to pick the problems, like decreased oxygen concentrations of breathing that patient. It might be of different causes, like either running out of oxygen from cylinders or misconnection of the oxygen cylinder with other source of different gases. It might be a problem. The other one, it might be an airway issue. It might happen like foreign body aspiration, commonly in pediatric childs. Also, bronchiolitis can be mentioned in adults, like COPD, which have problems in expiratory problems, or low respiratory tract problem might be an issue. The other problems that we might mention might be a hypoventilation. That means the patient might not be adequately generating good tidal volume, which might be a problem either centrally, like in the opioids, or sedative agent like benzodiazepines, and we can also be used for neuromuscular recovery, or like paralysis and peripheral muscle weakness might expose patients for hypoventilation, despite this patient may not have diffusion problems. And for the other causes might be a diffusion problem where the alveoli are unable or might be overflooded with different secretory problems or fluids, which might affect the diffusions of oxygen into the blood. Might help us to classify the cause of hypoxemia, because as I have mentioned, hypoxemia is mainly a decrement in oxygen concentrations of the blood, but further cascades might be mentioned after that, but that will be part of hypoxia. But as you have mentioned, I always agree with you, the listed problems and like COPD, asthma, ARDS, multiple disease problems might be listed, but the pathophysiologic mechanism might help us to classify our problems. And the commonest cause, usually it is ventilation perfusion mismatch is the commonest cause, but we can classify it, as I've mentioned before, as a pathophysiologic mechanisms, or the specific disease causes can be mentioned for cause of hypoxia.
Thank you, Dr. Jonathan, and all the participants. I think you exhaust all the list of hypoxemia from neonatal, childhood, and adult age groups. I think if you click on, an answer as a frequently asked, not now, Alana, just to tell them, for participants, if you go through the Learning Resource Center and click on the presentation, like what are the common causes of hypoxemia, there is in brackets, which is written as click. And if you click that, the document, you can see all the answer in video and so on. But to save time, we'll not be going there because everything there has been mentioned by participants and our panelists. But I would like to click on this long picture, okay? So can you do that, Alana? Yeah. So this was something Dr. Jonathan was also trying to say. And can you slightly zoom it, we can see, different way of classifying the cause of hypoxemia into four. Mainly hypoxemia can arise due to four pathophysiologic mechanisms. Either it could be an issue with alveolar oxygenation due to hypoventilation or low FiO2 level. Low FiO2 level is usually because of high altitude. When you have a high altitude, fraction of inspired oxygen available will be low. But hypoventilation could be of different causes. It could be CNS depression from drugs, or it could be an injury and the like. So if patients are having hypoventilation, then oxygen delivery to the alveoli will be reduced and patient can become hypoxemic. The other major cause could be a diffusion problem. For diffusion problem, alveolar or interstitial or vascular pathologies such as emphysema, pulmonary vasculitis is going to be one of the causes. And the other is a problem with oxygen binding after oxygen diffuses through the alveolo-capillary membrane. If it's not binding to hemoglobin and reaching into different tissues or transporting into the blood, it can lead to hypoxia or hypoxemia. And one of the problems could be carbon monoxide poisoning, but low level of hemoglobin also can be considered here. The other is VQ mismatch, what Dr. Jonathan was really telling us. It could be also a shunt. When you say a shunt, there is perfusion, but the area is not ventilated. Mainly the causes could be physiologic or anatomic. The physiologic are like due to pneumonia, atelectasis, pulmonary edema, ARDS. But other causes of VQ mismatch are like COPD, asthma, pulmonary embolus, and this should be known. So use this algorithm, which is readily available in the materials we are going to share, to know the commonest cause of hypoxemia, and also it helps you in the diagnosing and having the differential diagnosis for hypoxemia in your patients. Thank you, Alana. Over with this slide. So going forward, so is this 57-year-old male patient hypoxemic? You can see, his vital sign displayed on the slide as heart rate 95, saturation 89%, and blood pressure 95/52. Is the patient hypoxemic? Yeah, you can write if the chat box. Yeah, yes, right? Obviously, we are seeing yes. Yeah. So thank you. Can we just click on Alana to see what's written there? So many of you are saying yes, patient is hypoxemic. So the next thing to do is, to have these tools at hand in order to know what to do with hypoxemic patients. We have different tools available, like the oxygen wall chart. This helps in, how to diagnose hypoxemia, how to start your treatment, and how to escalate your oxygen, what devices to use. The same thing you can use, Lifebook's Triage tool, and also oxygen escalation tool. Three kind of tools are displayed here. And what I recommend you is to download or print those tool and utilize them for your practice on what to do with hypoxemic patients. And maybe in the next slides, we'll see the details of what each tools look like. In the meantime, while Alana is, opening those tools, can Dr. Jonathan say something regarding is this patient hypoxemic from the outset, and how can we say this patient is hypoxemic or not?
Okay, definitely. This patient is hypoxemic. As I've mentioned it before, you can use different methods or different device to pick whether patient is hypoxemic or not. And from the patient's vital sign, we can see the saturation was 89% with good pulse ox tracing. And the diagnosis might be different from individual to individual or from center to center, but usually it is recommended when the saturation or pulse oxy measurement, when it is less than 90 with atmospheric air, we can say that our patient is hypoxemic. So I can say this patient is definitely hypoxemic.
Yeah, thank you, Dr. Jonathan. So this is oxygen wall chart where you can post it at your setup. It could be in the ICU or in the emergency OPD or in the ward, and it has got everything. When you say patient's hypoxemic, and if you say patient's hypoxemic, then how are you going to treat? What devices are you going to choose, and in what step? The same thing is written in Lifebox tools as well, and you'll further explore that as we are sharing user materials. Now let's go back to an action item, and we'll proceed with the next discussion question. So now from your previous discussions, what action items can you take? You download and print the oxygen wall chart and also the Lifebox Triage tool, and you post them on your wall at emergency ward and ICU. And it's good to assign an equipment manager to process all contaminated reuse items, okay? Whenever you are using another prong or face mask and so on, there needs to be some form of decontamination process, and that needs to be assigned. Someone needs to be assigned to do that. And we'll see that also in the coming few slides. But now let me update you on the case. Let's say now you recognize right away that this patient is hypoxic because saturation of oxygen is less than 90% on room air. Now, also you assume that you are training a nurse student. So while you continue your interview and physical exam, you decide to administer oxygen therapy, and the student is asking you how much oxygen shall I be administering, and what oxygen delivery device should we use for this patient because he's already hypoxemic. So this is a question of discussion as well. You can see it in a blue box on the slide. What oxygen delivery device will you use? What flow, liters per minute, and what fraction of inspired oxygen can be administered with that flow? You can type it on a chat box. Yeah, so from Chernets, using nasal prong less than 5 liters per minute is acceptable. It's okay for this patient. Put him on up to 5 liters of oxygen via nasal prong is another nasal oxygen. Yes, very good. I agree with all of you. We can use concentrator or oxygen cylinder even as a source now. Dr. Amanuel is saying the source could be cylinder. From Gerida, Daniel, Nazar, Yeah, nasal prong 5 liters. So yeah, start with nasal prong and escalate based on response. Huh? Even better answer now. We are seeing more. Yeah, intranasal oxygen. Yeah, I'm very happy with most of the answer. So non-invasive one, start with non-invasive oxygen delivery devices. Very good. So, yeah, most of you, what you have said, Alana, is displaying, nasal prongs, cannula for different age group on how much this to start, how to make the flow rate. The different devices are being posted by Alana. Is very good. Even a Venturi Mask, most of you may not be familiarized with the Venturi Mask. It's something seen in the orange background. It has got, a pore to allow a certain fraction of inspired oxygen according to, the color is determined how much percent of CO2 patient is receiving. So it's not quietly available in our context, but the rest of the oxygen delivery device are present in our setup. So I think Jonathan also will be very happy to say something in this regard, right?
Okay, thank you. It was a really good summary. I mean, it tried to specify what and how we can use, because this is a pandemic period. It's mainly of hypoxemia or
Yeah, I think
pandemics of hypoxemia. Me well? And this is a good summary. As I've mentioned, usually this is hypoxemia and hypoxia pandemics of hypoxemia, and oxygen is a major form of management for hypoxemia, and we need to have effectively uses oxygen in this state of pandemic. Since we are resource limited setup, always it's recommended to start with nasal prongs and low flow, usually to the maximum of 5 liters. 1 to 5 liters can be provided, and it can provide up to 40% of FiO2, and we can see how the patient is responding. And when we are treating hypoxia, our target, or we need to monitor the patient's levels of oxygenation, and usually targeting saturation of 90 and above usually will be a good estimation, and we have to use our oxygen as effective as possible. And it's recommended to start with nasal bronch and trying to see how the patient is responding for that one. Just for the sake of time, I think it will be better to start with nasal bronch and escalating based on the patient response.
Yeah, I agree with you, Dr. Jonathan. So start simple, nasal prong 5 liters, and see the response. Initially, try to see if there is immediate response or not, and stabilize the patient. Once the patient stabilizes, then you can check the saturation every 15 minutes. And, it's good to have an algorithm for such kind of activities. And the good thing is the ones who developed this material at the Learning Resource Center can have, put for us a reference material. Like the Lifebox Triage tool is a very important equipment here. If you can show us that, Alana, I would like to go through the Lifebox tool on how to, start oxygen, and also how to escalate oxygen based on your finding. Yeah, you'll find it. Yeah, thank you. Yeah, if you go down the page. Yeah, using pulse oximetry for decision support for COVID-19. So let's see the algorithm. Alana, first page, please. Go up. Yes. So when are we going to use pulse ox, and what to do is really described here on using the Livebox tool. You start with, does the patient have any of the following, like if the patient have fever, cough, shortness of breath, or elevated respiratory rate, like in adults greater than 22, in children greater than 30, young children greater than 40, infants above 2 months greater than 50, or infants below 2 months in neonates greater than 60, or if there is any emergency sign of obstruction or severe respiratory distress, you are going to apply your pulse ox and measure. If SpO2 is less than 90%, then you have to start them on oxygen supported. What's recommended on this Livebox tool is to start with nasal prong, or in pediatrics with especially less than 5 years, you have to use a nasal catheter. And for pediatrics, you use a smaller, like 1 to 2 liter, but adults start with 5. Then, follow these charts. And it's SpO2 after 15 minutes. If it's less than 90 or above 90, there are things to do. If it's less than 90, for example, after oxygen administration, you have to think of admitting the patient to an ICU. But if patient improves, this patient can be transferred to a ward, isolation ward, or something, and be followed accordingly using this algorithm. Okay. So it tells you also, this algorithm tells you also when to de-escalate your oxygen support and when to escalate. So it's a very important tool. So it has to be posted everywhere in the ICU ward or emergency OPD, and will help you in managing your patient effectively. Yeah, thank you, Alana. So we can go back fastly to our presentation. So yeah, maybe the last point. Yeah. So are there any guideline for reusing disposable equipments? Do you have any guideline for reusing disposable equipments in your setup? So after using, those nasal prongs, mask, and the likes, we don't have a lot of them abundantly available, so we have to reuse it to our patients because we are in a resource limited setup. So at your setup, do you have any guideline how to reuse those disposable equipments? So from Muhammad, no, yeah, no. Anyone who can say yes. No formal guideline, but a common idea of reusing and clearing. Yeah, so very good point. So it seems like in our setup, we tend to use, common sense or some sort of, common understanding in all of us how to reuse them. Some of us may clean it just with an alcohol. Some of us may soak it in solution, and after 10 minutes and so on, wash it with water and the likes. But most are saying there is no any clear guideline. But as Alana is showing us, there is a WHO guideline for decontamination and reprocessing medical device of all kind. It also includes our, oxygen therapy equipments. So I think this is a good resource. Alana also will share this material, and you have to use that resource and devise one if you don't have a guideline, and if you have already guidelines, and strengthen it and continue to reusing your equipments after cleaning. Yeah. So Is there something you want to say in this regard, Dr. Jonathan? Shall we pass?
Maybe, yes, you have mentioned it appropriately. We might not stick to different guidelines, or we might lack a local guidelines, but the standard of care is usually it's not recommended to use such kind of device for reusable, but probably, as you have mentioned, resource limited setup might push us to use it again. And I try to see usually the classification medical devices can be like critical, semi-critical, and non-critical device. And this oxygen delivery device can be classified as non-critical because they are mainly in contact or topical contact with the skins and mucosal area, and usually it's better to start it.
Yeah, I think we lost Dr. Jonathan. He has I think difficulty in having a good connection. So Alana, if we just display the last slide of our presentation. Sorry for bothering you. Yeah, so as I previously was saying, there is a nursing student with you in the case, and if he asks you about where does oxygen come from, do we have enough for all patients, then I will not ask this time what will be your answer, because we'll discuss this issue further in our next session, which is about hypoxemia and management. You have seen the topics sent through email and also Telegram chat. So this is going to be our discussion points for the next session. I hope we have a very good time together. I just wind up the session by just giving you, reviewing through some practice change objectives and action items. So our today's practice change objective was for healthcare providers to follow recommended PPE guidelines. Healthcare providers are trained in all proper don and off sequence for PPE, isolate patients with potentially contagious infection, develop screening method for SARS-CoV-2, recognize and diagnose hypoxemia, use pulse oximetry to appropriately triage patients, and prescribe oxygen therapy using the most appropriate device available. And key topic areas reviewed are listed below. It's not visible. Alana, can you put? Yeah, that's. So we discussed, raised the issue regarding infection prevention and control, PPO recommendation, safe donning and doffing practice, how to screen COVID-19 patients, the triage protocol, how to diagnose hypoxemia, and how to use pulse oximetry as a triage tool, and how to start oxygen therapy and other non-invasive devices. And disinfecting, single-use equipment. Dr. Jonathan was saying how to, shall we disinfect a single-use equipment or not. The standard says, these are disposable equipment, but we are in a resource-limited setting. And there are guidelines from WHO recommending we can still use those disposable equipments if we effectively disinfected them. So thank you for your participation and following this session. We'll have also similar session after a 1 month period, and communication will be sent through email and the Telegram group. Feel free to write any comments, questions, or any additional points you want to have. The platform will also serve as, for a mentoring and remote mentoring and coaching activities. So if you have anything you want help or discussion, please communicate with us. Please take the action items seriously and change your practice wherever you are working. So I would like to thank all the organizers of this program, ECHO project, Assist International, Stanford Medicine, and also for all of you who participated in the session, including our panelists, Dr. Jonathan and Dr. Sophia. I really appreciate. And Alana for, her support throughout, making this session to be alive. Thank you very much. And yeah, if there is anything Alana wants to say, I'll give her a chance and we'll wind up.
Sure. Thank you, Dr. Ananya, for such a great presentation today. Just wanted to emphasize that you can visit the Learning Resource Center for the presentation slides and recordings, as well as additional resources, quizzes, case exercises, and videos, as well as the recording. These things will also be emailed to you. And do join us at session number 2 on Tuesday, June 29th. The topic will be diagnosing hypoxemia and pulse oximetry. The Zoom link